It's my pleasure to welcome you to this debate on balloons in the therapeutic armamentarium of patients with chronic sinus disease. All of you will know that balloons have been more popular in the US than in Europe, and it's very good to hear the views of different people on how we should deal with the potential position of balloons in the field of chronic sinus disease. And therefore, I welcome experts in the field. I propose we start with the first presentation, as this will then be followed by two other short presentations, and then we'll have an open debate on the position of balloons in sinus problems.
Very good, and I'm very pleased, thank you very much for the introduction, to introduce Entellus Medical's technology. The whole idea within Entellus is to provide a thought process around moving some endoscopic sinus surgery cases that may well be done in the main operating theatre into an ambulatory setting. The idea is to provide the technology as a quality product and to provide a value proposition that will ultimately reduce costs to the healthcare system. So there's a number of products that Entellus have internationally. The one that's most recognised is the Express Sinus Balloon System. But recently we've introduced a new technology called Cyclone, which is a technology for suction and irrigation. And again, it's been designed specifically to help patients in an ambulatory setting. So the product profile with Entellus is that all of the components allow the technology to be utilised in an ambulatory setting as well as in an operating theatre setting. But there's no necessity to have multiple components that need to be pulled together. It's one instrument for frontal, maxillary and sphenoid disease. Our new product, Cyclone, is for both irrigating and aspirating effluent that's in the sinus. It's been recently launched globally around both in the United States and particularly in Europe, and initial feedback has been excellent. So we've got a lot of benefits with Cyclone. I think the most important one is that when a patient is having a procedure and they're awake, they will actually not experience too much discomfort in having aspiration and irrigation in an ambulatory setting. The key thing with Entellus, though, is that we want to provide broader market support to the ENT community. Yeah, we're working very hard at the moment with clinicians like Ms. Hopkins to develop thought leader initiatives. We're also focusing very hard on reimbursement, particularly in state-funded healthcare systems. But the key behind Entellus, and I think over the last 5 years particularly, has been with regard to education and training. And we're actually providing a lot of support with cadaveric workshops, both in the United States and in Europe.
Thank you very much. I think we move now to the next presentation. So please, Agnieszka.
Thank you very much for the invitation. It's a great honor to be present during this meeting. When we think about the balloons, there are basically two concerns. One is technology, which means accuracy, and the second, indications and patient selection. There are a number of studies presenting the clinical value of this technology, made on cadavers, humans, long-term, short-term, comparative studies, and economic analysis. Primary technologies were based on the flexible or semi-rigid probe that used the illumination as an indicator of the position. And we know it works, but there are some papers posing the questions, and these questions are inspiration for development. This is one of the papers done on the cadavers, and it's an interesting observation that the guide wire missed the natural ostium and created a false passage in 10 to 10 times. Another interesting arising questions study, which is presented on this slide, touches the topic of the limitations of the balloons when we do the surgery around the frontal sinus. We have some situations, because of the nature of the disease, because of the anatomy, that could create the problems for the surgeon. So what could be the answer? What could help in this kind of situations? An image-guided surgery could be the potential help to the surgeons. So the couple of years ago, the new vent appeared on the market, and it was the answer for the needs of the surgeons who looked for the solution to help them in the interpretation of the anatomy. And it was the response to the needs of the surgeons. So the new vent system is the dilatation system in the only balloon technology that offers built-in electromagnetic tracking for placement, the position of this rigid seeker. And it's going to help to identify, to control the maneuvers of the surgeon. It's very simple and consists of the 3 parts and has 3 different solutions for the frontal, maxillary, and sphenoid sinus. So what we know today, there is a positive position statement of American Academy and American Rhinologic Society. But when we look at precisely to this position, we can find out that the final decision is in the surgeon's hand. What kind of patient we select for this kind of procedure and who is the best candidate. We know today that the balloons could be used as a standalone procedure or in combination with other instrumentation, cold instruments or powered instrumentation. When we come back to the studies, there is a systematic review and meta-analysis shows that indications for the balloon sinus dilatation are not different from those for the endoscopic sinus surgery. We know that the patient must have changes in CT scan. We know that the balloon dilatation is limited to the frontal maxillary and the sphenoid sinus. And we know that the patient must not be responsive to the medical therapy. Another one of the last studies on the large group of patients and very detailed analysis confirms the improvement of the quality of life of the patients after this kind of procedure. That the standalone balloon sinus dilatation can be performed as an in-office procedure with faster recovery, decreased post-procedural pain, and less requirement for the debridement. And these findings suggest that for the patient with uncomplicated sinusitis, standalone balloon sinus dilatation is an efficient and effective management option. So the question is it going to be our first-line treatment in this group of patients? What is the final decision process for the surgeon? And what could be next? Can we do something more with this tool? Can we add this technology to the skull-based surgery? The Bedrosian published the case of the cholesterol granuloma when they used in the combination of the skull-based surgery the dilatation to improve the drainage of the operated area. Can we use the dilatations, one or multiple, in our revision cases of the frontal sinus? And last not least, in office procedures. It's another big topic, big area for the discussion. What could we do having the balloon dilatation for our patients? So concluding, we could say 3 different things. Yes, we know that balloon sinus dilatation works when the ultimate aim of the surgery is to restore patency of the sinus ostium. The balloon dilatation combined with IGS increases accuracy of this relatively straightforward procedure. But there is a big need to distinguish what is the role, who is the best patient, best candidate, what we can achieve, and what are the limitations of this technology in contemporary rhinology. Thank you.
Thank you very much. I now invite Dr. Claire Hopkins to present on a different type of balloon.
So I'll be presenting some data on behalf of Sinus, a company who unfortunately were unable to come here today to attend. So none of this data is actually my own, but they have modified the concept of balloon sinuplasty, which relies on high pressure, rapid inflation of a balloon to try and use osmotic dilatation to achieve slow dilatation of their device. The ethos of their approach is that it is very simple and they feel it can be learned by anyone in ENT. Because it is very low pressure and slow dilatation, it is easily tolerable under local anaesthetic, so that it would truly be very much a one-stop procedure where a patient could return to work on the same day. So they would place it as similar to going to the dentist rather than coming in for an operation. So they started off the technology looking at the maxillary sinus and developed the Ventos. The idea, as I said, is you insert the device across the natural ostium. It imbibes fluid from the surrounding tissue and gradually dilates over a period of about 60 minutes to reach its maximum size. The idea would be it would be placed in the patient under direct vision. The patient could be sat in the office quietly reading for an hour, and then a nurse or assistant could remove the device and the patient could go home. And they've demonstrated patency with some initial studies. This is showing that the device is placed in under direct vision, and they presented their results at the ARS in 2014. If we go on to the next slide, you'll see the summary of their findings, where they found comparable patency at a year to balloon studies, showing that about 90% of patients, the maxillary sinus ostia was clearly and widely patent at a year. And these are some of their examples. And if you look closely at the photos, it does appear to dilate the natural ostium on the view with a 30-degree endoscope. They've recently moved on to develop a frontal dilatation system. It relies on transillumination to ensure correct placement. It has a small probe that will be advanced into the sinus, and then the Ventos device is advanced over that. Now, undilated, the device is about 3 millimetres. After 60 minutes, it dilates up to 4 millimetres, and then after 90 minutes in total, it dilates up to its maximum diameter of 5 millimetres, and again, could be removed by an assistant. This is one of the first in-man studies with Hesham Saleh in London, and again, you can see transillumination, much like some of the other sinuplasty technologies, and the device being inserted in this case in the theatre. This is the view that you can see after removal of the device having been left in place for about 60 minutes. So this isn't quite at the maximum diameter. And this is the case in which it was used. They've recently also developed a sphenoid dilatation device. So very much like sinuplasty, they can only address the frontal, maxillary and sphenoid sinuses. And I think that's important to note when we talk about comparison to FESS. They have been enrolling into a trial to look at the frontal and sphenoid device since October 2015, and now have a total of 30 patients treated, 32 frontals and 15 sphenoids. They were successfully able to place the device in all patients and have a frontal patency rate of about 90%, which is again certainly comparable to the balloon and conventional FESS techniques. So the idea is, as they said, that it is slow dilatation, but at the same pressure, therefore being much less traumatic to the patient and the surrounding tissues. So it should be easy to do in an outpatient setting. And they are trying to position themselves at a lower cost than some of the other technologies. So the estimated cost in UK pounds would be about £200 per device.
Thank you very much for the excellent presentations. I would like to start off by asking the 4 experts in sinus surgery to share and disclose their experience with balloons, because that will help us to understand what is the next step, and that will then also be the basis of further discussion on patient selection, cost effectivity, and so on. But I would like, for instance, know from Manuel what is his experience and how he sees balloons in daily practice at present.
Thanks, Peter. I have to say that my experience with balloon is very, very reduced. There are several reasons I cannot use balloons. First, we don't get reimbursement in Spain. That means that if I use something which adds cost to my daily practice, my hospital will cut that down immediately. And that is one of the main reasons I cannot use them. We do not get reimbursement for using devices in the outpatient facility. So whatever I use there increases my costs, but I don't get the reimbursement for that. So basically, we, from that point of view, we are unable to introduce these devices in the hospital.
Sanna?
There are most probably very good indications of balloon sinuplasty. However, I think that we need also very good controlled and prospective studies on these indications still.
Andreas?
My experience with balloon is limited. However, I have experience. We did around 50 cases the last years. I think it's a nice tool which helps when you find the right indication. I think the indications are limited. However, when you have a focus on rhinology and you are representing a reference center, I think you should have it in your armamentarium to make really a good treatment for your patient, because the aim is always to do a personalized treatment of the patient.
Wytske?
The same for me. I have very limited experience, and it's a combination of reasons. Not reimbursed, although I think our university hospital, if it is really worthwhile, would pay for it, like they pay for shavers that are not reimbursed either, or navigation that is not reimbursed either. So I don't think that is the main argument. What I see as the biggest limitation in my practice is that most of the patients have very severe disease. And only doing a balloon is not enough. So it is only for a very limited group of patients who have had surgery and then have scarring of a frontal sinus, or had extensive surgery and it is reclosing, situations like that. So that's very, and in that situations, of course, the evidence at the moment is next to zero. So we need more evidence. What is the exact role there?
So you already bring up the issue of patient selection, which is a very important topic to discuss as well. Would you agree, Claire, that the majority of patients that are having recurrent disease or that fail routine FESS may be good candidates, or would you also consider those with recurrent acute rhinosinusitis as being candidates for balloon sinuplasty?
So patient selection is key, and a lot of criticisms of the technology are actually criticisms of poor application of the technology. And I think one of the problems is we see a huge polarisation in surgeons who would never use a balloon, or who would use a balloon in every case and would never offer a conventional FESS, and that's clearly wrong. I think that patients with limited disease, where the pathophysiology isn't an underlying inflammatory condition, where we know it's not primarily a disease of obstruction, are people in whom I'd consider the balloon. It's probably still only about 5% of my patients with chronic rhinosinusitis overall who I would consider. But for people with conditions such as recurrent acute sinus disease, which may be triggered by osteal obstruction, or patients with isolated maxillary or frontal sinus obstruction, which is symptomatic, I think they are quite good candidates. And it does allow a selected group of people to be treated under local anaesthetic with a much quicker return to normal activity.
Would you agree with that, Manuel?
Yeah, I probably might add pneumosinus dilatans. That would be a good indication, for example.
We heard also some different approaches for placing the balloons. They could be placed under general anesthesia, they could be placed in an outpatient office. From my perspective, if we would consider balloons as a good therapeutic option, and I think Andreas would agree with that, it should be most ideally be an opportunity that we could offer to the patient as a non-surgical approach in the outpatient office. Would you support that view, or do you have a specific opinion on that?
Why not? But we have to consider when we do a simple nasal endoscopy, and you remember you do a local anesthesia and you touch the middle turbinate, I think the patient will not be amused by this, and some patients feeling really pain. So I think we have considered this. So in the primary case, it can be painful despite local anesthesia. However, when you do it in revision cases, and I have experience, however limited, I've done a small series on previous operated cases, and I think it worked quite well, but this is due to open spaces, only having some soft tissue restenosis, we can make a very nice dilation. So in general, yes, but you know, it's a single case. You will see if it's working or not.
Sanna or Wytske, do you have a strong opinion on the pain that is associated with balloons, or the positioning in the outpatient clinic versus the operation room? Do you have a strong opinion on that, or could you comment on that?
I think in Finland it's not that a big problem, because we do also endoscopic sinus surgery in local anesthesia, small ones. But of course it's a more global problem, I think. Pain.
I agree. You can do a whole FESS in local, so definitely you can do a balloon in local. But of course, it's only interesting and relevant is if the time of surgery is limited. So it will be very interesting to see how fast can the whole procedure be done in an outpatient clinic. If we compare it to the dentist, dentists usually say that an hour is about the time most people can tolerate to be in a chair with their mouth open. So how much can we achieve in an hour? That's probably a good limitation.
We have heard different techniques with some advantages and disadvantages related to the different approaches. But when it comes to the dilation, do you think it really makes a difference if it's a dilation based on osmotic pressure versus dilation being more physically induced by a balloon? Maybe Claire first, and then I make a round, because that's a crucial question as well.
I'm not convinced that slow dilatation is going to be a huge advantage over rapid in terms of the long-term patency. It may be less painful for the patient, however they have to spend longer in the office, so it's a trade-off. When you inflate the balloon under local, there is a moment of discomfort, and patients will react to that. It's not hugely painful, but it is, you know, at high pressure with rapid inflation, they are aware of it. It hasn't prevented me from going on to dilate a second side, so it must be at a reasonable level. So.
Would you agree with that, or could you give another opinion?
I'm biased, and of course I would agree with that. I've had the benefit of working within the balloon technology for over 11 years now, and what I've actually seen from a lot of your colleagues is how their utilisation of the technology has evolved over those years as well. Originally, it was very much focused on messaging that the balloon was better than endoscopic sinus surgery, etc., etc. As people get very excited about new technologies, and that was completely the wrong messaging. And as it's evolved, as I think endoscopic sinus surgery has evolved over time, the technology finds a place. And probably now, given the state of some health systems around the globe, the move from the main operating theatre into a more ambulatory setting is a really pertinent point. And just coming back to what Dr. Leunig was saying, there's a move now within the healthcare systems, not just within ENT, but in other specialties as well, to actually move things out of the main operating theatre into a different surgical site. And honestly, the balloon technology fits that perfectly.
Could I just pick up on that? Sorry to interrupt. I think there is a danger, however, in assuming that every patient that currently has a FESS could be a candidate for a balloon in an ambulatory setting. And,
agreed.
And that would be a big
agreed.
mistake. It's not, you know, it is personalised precision medicine. We want to select the right tool for the right patient.
Absolutely right.
And not see it as a cheaper alternative to cut the costs of the system. That would be unfair to the technology and to the patients.
I support 100% what you're saying there. But I would also like to address some of the clinical data that you've worked on recently, where there's a discussion around patients being managed earlier in the disease process. When I look around the room, I'm seeing clinicians that are working within tertiary referral centres, and the type of patient that you're seeing are probably fairly late on in the disease process. And there are lots of patients out in the community that, when refractory to medical management, may well benefit from an intervention with a technology like a balloon, rather than having to have an endoscopic sinus surgery straight away. And so what we're seeing is that there are a lot of clinicians that are seeing that the balloon has a place. And if you have a continuum of chronic rhinosinusitis and you look at medical management and then endoscopic sinus surgery, I think the discussion now is, where does the balloon actually fit in that continuum? And obviously it's about patient selection, but logic would probably say that if a patient is earlier on in the disease process, then perhaps the balloon is more suitable earlier on in that disease process, rather than waiting for patients to have polyps. And where, quite honestly, if the patient has severe polyposis, then the balloon's probably not the right tool.
From the surgeon's point of view, I definitely agree. I mean, it's an instrument, it helps to complement all the different steps we can do with FESS. Perhaps there's a case who has obstruction and we need a very soft instrument to dilate. So which patient fits for this instrument? That's the main question, so patient selection. And I agree, definitely individualized treatment, that's what we should focus for. And that's why the balloon can have a place, but once again, patient selection, it's a key for the success of balloon technology.
Absolutely. And to your point about utilising local anaesthetic, and Professor, you were saying about you can do full-blown endoscopic sinus surgery under local anaesthetic. What we're seeing is people are actually refining their local anaesthetic protocols, utilising the balloon technology, and that's also how the technology has been evolving over particularly those last 5 to 6 years. And the patients are tolerating the procedure very well.
Agnieszka, can I invite you to share your opinion?
Yes, as far as the technology is concerned, navigated balloons work slightly different, particularly Neuvent. It's a rigid probe, so the technique is different. And when you have very complex anatomy, you probably have to go step by step, if we talk about frontal sinus, to follow drainage pathway. And what is the benefit? That probably you could consider safer approach in the more complex anatomical situations when you have to do something around the frontal sinus. This is just a technical comment. I believe that the balloons could be seen as in a kind of extreme situations, very simple cases, very complex surgical situations. As we had a discussion about early intervention, first line, etc., when you have very limited disease performed in office or in operating room. And this is a standalone situation and has to be, again, perform the studies to define what's the role, that we have enough evidences, who would be the better candidate to do the balloon dilatation or conventional sinus surgery, even if the disease is limited. And there is this all kinds of different complexity of the severely ill patients. Imagine that you have a patient after a revision of the Lothrop again and again and again, as it was discussed here, and you want to do a dilatation and again and again. And this is just a tool, one of the tools we have in our operating room. And some of the situations could appear in office, when the patient comes for the debridement and you see you have a restenosis, and it would be lovely to have a balloon and make just dilatation. Or I know the clinicians who use the balloons when they do revisions of very severely ill frontal sinuses as a kind of substitute for mini trophonation. When they look for the identification of the ostium once they continue with cold instrumentation of powered. And these are probably situations we have to define, we have to analyze. And so we can think about the balloons as a procedure or one of the other instrumentation we have, powered, Blexley, or all kinds of different stuff that are available. And where is the key problem? Reimbursement system.
I think Manuel may comment on that strong
I
statement.
like your point very much in difficult cases that may substitute trophonation, which I personally do not like that much because it adds an external approach when in fact we should be able to solve this from inside. The question is, you want to bring a balloon into the outpatient office and you are using that back into the operating theatre? I understood that well?
I don't think that there's actually too much difference between the two companies actually at this moment in time. Our technology is used both in the operating theatre and in the ambulatory setting. What we're seeing though is that the health systems are demanding that things should start to move into a different surgical site. Be it day surgery, be it in an ambulatory surgical setting, it could be an office environment, as it has turned out to be in the United States. But we're seeing, particularly in the United Kingdom, a move at the moment of a lot of these types of surgery that can be moved into an ambulatory setting to move into an ambulatory setting. And it's actually, as I said, it's being demanded by the system more than anything. But when I see clinicians utilising this technology in an ambulatory setting, what comes across to me is that the patients are tolerating it very well. And I think that's the thing that's really exciting, that patients are tolerating it very well. The time for surgery is much less very often. And again, it's about the patient selection. If you're choosing the right patient, then the procedure moves very smoothly in that setting.
Can I ask a question?
Yeah.
To you, how do you think we prevent... we all know that in many patients chronic rhinosinusitis is a self-limiting disease, or something which we can solve with medication. We have big challenges in diagnosing. CT scan is not very sensitive. Endoscopy is quite difficult to say whether it's actually chronic and will remain, or is recurrent acute, or will solve itself. So how are we going to place this treatment in an office situation to tailor it to the right patient?
Well, I mean, you're not going to do anything really different to what you're doing currently. You're still going to have the CT, you're still going to put the scope inside the patient's nose. But what we're seeing is that where you've got architectural abnormalities in the patient's nose, that the balloon dilates very nicely and then allows medication subsequently to get to where otherwise it might not have been getting. And so that's what we're seeing more and more, is that the patient selection And that's where it's really evolving, and has done over the last 4 to 5 years, is that the patient selection has become critical.
Yes,
I just want to pick up on something Wytske said. You're right, I think a lot of patients with early disease have self-limiting disease, and we need to be careful that we don't extrapolate some of the data about the benefits of early intervention to becoming the benefits of, or the detriment of, too early intervention. And the driver for that research was that in the UK, treatment is hugely delayed and the average time to surgery is 5 years. But I think one of the risks with adaptation of some of the new technologies is we've swung the pendulum too far the other way, and people aren't being allowed to have a course of maximum medical treatment and have time for spontaneous resolution, and they're being driven straight to an intervention, whatever that may be, and I think that's wrong. And we need to have appropriately timed intervention with whatever that may be, and we mustn't let reimbursement and other drivers push us to surgery or balloons at an early stage.
Agree, Claire. I would add to that, though, and that if you look at the healthcare systems that we suffer, if you like, in Europe, there are so many patients that are many months, if not years, suffering from chronic sinus disease. And we're seeing a lot of those patients now coming forward because they're able to have a technology which hopefully will be less invasive from the beginning, but then you've always got somewhere to go after, you know, with revision surgeries and things. But we're seeing a massive uptake in moving to an ambulatory setting, and more interest. But I hear you about the reimbursement, you know, people moving too quickly.
I think we have to differentiate between two groups of patients. First of all, a patient having anatomical variations having or leading to problems. So the balloon could fit in this group of patients very nicely. And we have the second group, and that's why I like Wytske's comment on the chronic inflamed patient. That's a different kind of patient. And I think we are on the way. We are not finally reached our goal, but we are on the way having better subtyping, endotyping of the patient. And perhaps this can give more support in a proper patient selection, getting the right patient for the right treatment. Yeah. And I think we are on the way, and so that's why we are here and discussing it.
Just one comment to your question. And the balloon sinus dilatation is a solution for in-office procedures in certain cases, as you mentioned. Probably when the patient has very complex anatomy of the frontal sinus, probably is not the best candidate for the in-office procedures, as well as the operating room as the best place. I remember some years ago I did a surgery of the monk who had a head trauma after accident, and I made the dilatation in OR, the frontal sinus here, the pain of the scarring. And today, probably I would take him to office. I wouldn't have to take him. He didn't have any inflammation, just change the anatomy after trauma of the head.
The question was only because you were using navigational driven systems, and we have one, but we cannot have two. One in the operating theater, one in the office. That would be very expensive for us. But that was a question, so why?
I like your point to use the balloon for a complex anatomy. However, we published on this subject and we tried to find, you know, the limitations of the balloon, not because we are not liking the balloon, but we wanted to highlight what's a patient where you should not use the balloon, and especially complicated anatomy. I'm not sure we as well overlooked pathologies using the balloon. That's the second point which should be considered. So you do not look at the pathology. And we had one patient having had a lymphoma, and we didn't know before because we didn't take histology. So this is a very, very important issue.
Absolutely.
You have been bringing up the issue of patient selection, and would you agree with me that we could consider balloons in CRS without nasal polyps, and that actually in a nasal polyp patient it is not of an issue, because it may be important to strongly state that as well? Would you agree, for instance, Wytske?
Yeah, I don't think there is any, I don't see any role for balloons in polyp patients. But
Would you
if
agree
you
with that,
disagree, I have to be convinced.
Up to now, yes. I mean, perhaps there may be combinations out of balloon and other, I don't know, devices, but pure balloon for nasal polyp patients, I don't think, because it's inflammation and we have to reduce and control inflammation.
Sanna, you're always very keen in doing studies and designing academic trials in the field of rhinology. What trial could convince you to start using balloons, for instance, in the patient populations with recurrent acute sinusitis? Because for me, that would be the patient group that may benefit most from a trial with the balloon sinuplasty rather than doing a full FESS in a patient who is suffering from 6 episodes of acute sinusitis on a year. What trial could you think of that would finally convince you to start implementing the balloons in daily practice?
I think that kind of trial should have a very big patient number, first of all. And the problems in clinical trials, they of course, they have to be, to my opinion, sham surgery controlled or alternative surgery, which would be then endoscopic sinus surgery. But I would prefer sham surgery control. And the number, I mean, the patient population should be very, there should be very different extent of disease and also general diseases, because the problem is that if the patients are, if the inclusion criteria are very strict, we can't implement the ideas, the findings to the general patient population. For instance, not only polypose CRS, but I think in non-polypose CRS patients, there are several that have immunodeficiencies or aberrant immunity without clinical signs, and asthma and so on. And we really have to study these patients very carefully. Which kind of surgery do they benefit from, and what are the long-term effects of the surgery, and if we need, for instance, some samples, microbiological samples, lavations in the future, can we do that after balloon, or that kind of things too. So long-term follow-up and big size of the sample, so that we can also study the potential confounding factors.
So we mainly discussed the patient selection, the different options that are currently available for balloons. We did not touch upon complications. Are there any complications reported, and what is the fear that we are having as rhinology community regarding balloons? Could you start off with sharing your opinion? Because sinus surgery is associated with some risk for complications. What could be your estimated likelihood of any risk and danger of balloons?
So I think one of the initial attractions for me with the balloon, particularly with the flexible navigated guide wires, was that it seemed inherently a very safe procedure. You are placing a wire without resistance through a natural ostium before you advance anything over it. What we've seen with some of the technologies as it's evolved, and in part with the drive to reduce costs, not necessarily the ones that we've discussed here, but some of the things that have come on the market, is that they have compromised on some of the safety aspects. So instead of a very soft, flexible guide wire, we're now introducing rigid probes, and sometimes, you know, I saw a proposal for something without any guide wire or introducer at all. And when you're coming to place a rigid structure up potentially into the frontal recess, if that's placed incorrectly, I think you are going to see intracranial penetration. You know, there are techniques for both of the companies here today to avoid that, but I think we do need to be mindful of it. Any instrument placed in the wrong place can cause harm.
You will find some reports about complications using the balloon technology. For instance, anterior-skull-based single cases, but they happened as well. Perforation or penetration into the orbit, laceration of the lamina papyracea. They are published. I had a look at it, and I mean, they are single cases, but you know, I mean, it's always a question of the surgeon who's guiding the instrument, and it's not the balloon itself. But it can happen. This should be kept in your mind.
Before we close this debate, I would like to invite you all to make a final statement on your impression of the balloons and how we need to move forward in the field. Wytske, do you have a strong statement at the end of this debate?
I think for Europe it's extremely important that we have large-scale studies comparing balloons versus medical treatment, for example. Or so not comparing to FESS, but comparing to another less invasive treatment to show what the advantages over time are. And that is and in that way try to further endo or phenotype the patients that will benefit from the disease, because at the moment there is an enormous lack of proper data to make decisions on.
Andreas?
Yeah, I agree with Wytske, and just two more comments. The balloon technology, it's an instrument, and it, gives you more options for your patients. However, patient selection is the key for the success of balloon technology.
Okay, Sanna?
I agree with you. So I think I have nothing to add now, but of course we need really good studies and different kind of studies of different hypotheses or aims also.
Mm-hmm. Okay, Manuel?
I would say that I will skip the chronic rhinosinusitis for that purpose. I see clear indications for a single balloon use in cases of acute rhinosinusitis, purulent acute rhinosinusitis in the frontal or in the maxillary. You can see an indication in dentogenic sinusitis, provided there is not an aspergillus mass inside, which you will not be able to remove. And I could imagine that we might be able to use that under topical in the emergency room, where we are seeing these patients who perhaps have to fly back. We are living in a touristic city. Some people come with an acute sinusitis and have to fly back a day later, and you cannot allow them to fly back. But if you dilate, if you are able to remove or suction the pus away, whatever, that will bring relief and enable them to fly back. So I see an indication for that. I will not touch the chronic rhinosinusitis, as has been said. We need more information there.
And Jessica, you would like to add anything to the discussion?
Yes, I would say that the first challenge for balloon sinus dilatation seems to be solved. I mean, the technology. We have a tool which is safer because it allows us to control all the time the position of the seeker. As Claire mentioned, if we use the rigid probe the same way as the wire, we may create the problems. We have to remember that we do this dilatation in a different manner. So we have a tool. And now there is a bigger challenge to define who is the candidate for this procedure. And definitely there are patients, no question about it, no question. It's just the responsibility of us to define who, when, what circumstances, in office, or etc., etc. And this is the challenge for us physicians.
So I would say that there's probably two challenges within the international marketplace today. One, I think both companies would like to know from the clinicians what clinical data is actually needed, because one of the things that the balloon has actually gone through over 11 years is criticism that there's actually not a lot of data, although when you review the data, there's over 150 clinical papers, many randomized clinical data sets as well. And if that data isn't sufficient, then we would actually welcome guidance from the medical community to help us get those studies put in place. I think the second thing is something that, Manuel, you mentioned about, and that's reimbursement. I think there's probably also a very important place to do some data collection around cost effectiveness to see how it can actually be a cost-effective management of a patient.
Thank you. Claire, final comment?
So I'd like to follow up on both of that and really take on board your question as well. I think, you know, it is a useful instrument, but what I would love to see is where its place is in treating patients at an earlier stage in comparison to control or conservative management or FESS, to see if in that group we can reduce their longer term costs in healthcare utilisation. And I think a study that would address that with maybe 2 or 3 rounds of randomisation from patients at an earlier stage would be really interesting.
Right. Thank you, Claire.
So I then now have the pleasure to close this session, but I cannot hide my excitement because, first of all, we have met our aim, which was to bring industry together with the key opinion leaders in the field, discussing and brainstorming about the joint future. And we raised the issue of personalized care a couple of times and the personalized approach, which is fully aligned with the mission of EUFOREA. So I'm very excited, and I thank you all for having contributed to this debate. Thank you very much.